Okay, hey everybody, this is Michael Ingram here with Simply Psych EDU, part 4 of the ADHD series, the treatment. So how do we treat ADHD in adults? This is a very quick lecture. I don't want to go into too much detail. I think there's a lot out there about the treatment of ADHD. I'm spending the most time on medications, mainly because that's my expertise, but there are a number of psychotherapeutic interventions which are very important in ADHD treatment, and if there's some interest in hearing more about those, I'm happy to do that in the future. But this is going to focus mainly on the medical treatment or the pharmacotreatment of ADHD in adults. I have nothing to disclose. I don't make money off of these lectures. Medical legal disclosures. This is educational only, right? I'm not providing direct medical advice for you. Ask your physician. I'm not a child adolescent psychiatrist, so I will be talking about the treatment in adults. And then the patient LB, which we will talk about at the very end, the very last lecture, is a case study which I introduced in the very first lecture, but we'll come back to and I'll summarize in the very end just about what happened and how her case was really a successful case and also a very complicated case, which I think illustrates many of the issues when it comes to treating ADHD in adults. Diagrams, illustrations from this particular series come from a number of different books. Some of them are put there. That's me. Those are the learning objectives. I show you them every single time. Okay, so the treatment of adult ADHD, again, we're talking about the medical treatment. We're not going to be talking too much about the psychological treatment, although it's extremely important, and I'm willing to do more with it if there's interest. But I'm specifically talking about medication management. And the reason why I'm talking about medication management is because it's first line. So in adults, pharmacotherapy is first line. In children, it's a little bit different. But in adults, pharmacotherapy medication is first-line treatment. That doesn't mean that medication is for everybody. Not everybody responds well to medication. Not everybody's interested in taking medication. That's perfectly fine. Then you can start with behavioral interventions. But if there's interest in taking a medication, if there's if they're open to pharmacotherapy, it's certainly first line. The reason why I say that is because many times you need both, right? You need the medication, but you also need the behavioral interventions. And it makes sense. And why do we put pharmacotherapy first? Well, we put pharmacotherapy first because you want to be able to participate in the behavioral therapy, right? So in order to get there, right, when I think about psychopharmacology in general, I don't look at psychopharmacology as a way to treat and cure psychiatric disorders. You can't, right? But what it can do is sort of give you that boost enough to where you can do the things in your life that will actually ultimately lead to long-term improvement and recovery. So at the very end there at the bottom, so you can see you go through this list. So pharmacotherapy is first line, then behavioral therapy, then family and relationship support, although that's more relevant in kids. And finally, the treatment of mild depressive and anxiety disorders. And I put that last. And the reason why I put it last is because many patients with ADHD have comorbid anxiety and depressive disorders, and if you treat the ADHD, many times those disorders they improve. And so what I'm trying to nail here is that we should be treating the cause, not everything else. All right. So what I mean by that is when you're growing up with ADHD, you're struggling. You develop coping mechanisms, whether it be obsessional thinking, whether it be anxiety, whether it be self-doubt, whether it be low mood because you've been just told your entire life that you just need to work harder, you need to do this, you need to do that. Why are you lazy? Why do you care about your future? Blah 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 blah. Right? Horrible things you've heard as you're growing up, not very encouraging things. It's going to make you anxious. It's probably going to make you depressed. All right. So, but the thing is that if you can target the ADHD, if you can get the patient focusing and you can get the patient not feeling so restless, then maybe they can sit and actually do the things that they want to do, which ultimately is not going to make them feel anxious and depressed all the time, okay? So I say that because many times you'll see patients come in, yeah, I have ADHD, bipolar, schizophrenia, generalized anxiety disorder, panic attack, it's like 8,000 different diagnoses with 10,000 different medications. And it's really, if you treat the ADHD, you may only have to use one medication. So, and I've seen this, and in fact, the case that I'm going to describe and explain to you at the very end of the series, the very last lecture, which is the next one, you will see that she came in on like 5 different medicines, and we got down to 1, and she's doing wonderful. So I think this is a very, very important thing to know, that many times patients are overprescribed, not stimulants, they're overprescribed all the other shit that just like they're trying to treat everything but the elephant that's in the room because they're more quote unquote comfortable treating all the other stuff, which doesn't really make a whole lot of sense from the standpoint of looking out for the patient's best interest in terms of taking the minimum number of medications. Okay, so overview of adult ADHD, it's an integrated multimodal approach. We know that multiple studies have demonstrated beneficial effects of pharmacotherapies for the core symptoms of ADHD in adults. It's been well studied. It's similar response that we see in kids. The attentional deficits and motor deficits, not deficits, the attentional deficits and the motor restlessness that we see in ADHD, best controlled with pharmacotherapy. This idea that you can only use pharmacotherapy for one or the other is complete bullshit, made up, doesn't make any sense. You can use it for both. Motor restlessness in adults is sort of the equivalent of the childhood impulsive / hyperactive type behaviors. Why is that? Well, there's many reasons for that. Adults have a much more matured frontal cortex, and because of that, their cortex and their subcortical structures are interacting differently with one another than when you're a kid, and so this ultimately, in a very simplistic way, by the way, what I'm saying is very simplistic, will change, the manifestation of your symptoms. So treatment should focus on behavioral interventions, like I said, involvement of close relationships, psychoeducation. This can be a little bit more difficult in adults. And then treat the residual symptoms last. So, for example, the mild depression, anxiety, if that's still left over after you've treated the ADHD, then you can treat those things last. So stimulants, 2 classes of stimulants, methylphenidate and amphetamines. What do? They both target dopamine and norepinephrine systems in the brain, and I want to quickly sort of talk about this briefly. So in individuals with ADHD, we believe there's a problem with how the brain is processing sensory input. So our brains they spend an enormous amount of energy, up to 20 to 30% of all energy in the body, to do many things, right? And most of the things that the brain's doing, you're not even conscious of. In fact, only a very small percentage of the brain activity contributes to your conscious awareness. The rest is all the unconscious processing, integrating, analyzing of information that will ultimately determine our behavior. So much of the brain's energy is spent sort of quote-unquote deciding which signals are relevant and need to be recognized and brought to conscious awareness. So if you think about all the stuff you do that you aren't even aware of, I mean, you do it all the time, right? So when you're walking down the street and you're talking to somebody, I mean, are you actively feeling your right big toe? I mean, you're probably not thinking about your right big toe, hopefully not, while you're talking to somebody walking down the street. Unless your right big toe is inflamed or has gout or something where it's like in extreme pain, at that point you would have an awareness of it and you would be thinking about it because it is relevant. But if not, that's not relevant. It's not relevant to what you're doing. It's just not relevant at all. So your brain spends an enormous amount of energy sort of filtering out, so what is important and what isn't. And so dopamine and norepinephrine, they're 2 chemicals in the brain, and they act like sort of guitar and piano tuners. So it's like a guitarist or a pianist when they're playing a song, they can play it perfectly with the right chords, strings, and keys at the right tempo, but the sound of the song, if the strings are out of tune, it just sounds off, right? So what dopamine and norepinephrine do, or they do many things, but one of the things they do is they tune the brain, right? So they modulate the activity of many different neurons, particularly the glutamate neurons. So they help your brain decide what you should ignore and what you should focus on. So these are two separate systems in the brain, but the medications like the amphetamines, like Vyvanse and Adderall, or the methylphenidates like Ritalin and Concerta, and bupropion like Wellbutrin and amoxicillin like Strattera, they all, and actually some other antidepressants also, they all are thought to promote dopamine norepinephrine, and therefore, because they increase these chemicals, they are thought to help sort of tune out the extraneous signals coming in that you just don't need, but keep the relevant information flowing smoothly. So you could also think of it sort of like a garden hose with holes in it, right? So one chemical is sort of affecting the pressure. So you got a garden hose, you need the water is the information, it's got to get somewhere. Well, in order for that information to get to where it needs to go the quickest, you need to have high pressure and no holes, right? So one chemical sort of affects the pressure, and the other one sort of plugs the holes so that the information gets to where it needs to go. I think that's probably a better analogy. Again, that's very simplistic. The brain's much more complex than a garden hose, but I think that kind of helps put it into perspective. So when we think of dopamine norepinephrine, we're really talking about the fine tuners in terms of what are we going to ignore and what are we going to focus on. Amphetamine and the methylphenidates affect both of these systems. The amphetamines and the methylphenidates, they increase the concentration of these neurotransmitters in the synaptic cleft. How do they do that? Well, they block the reuptake of these monoamines, dopamine and norepinephrine. They block the reuptake of these monoamines into the presynaptic neuron. Amphetamines have an additional property of actually promoting the release. They'll actually flip the release, or they'll sort of flip the switch on the reuptake transporter so that dopamine is now sent out or released into the synaptic cleft. So it's not just a reuptake blocking mechanism. It's actually a potentiating mechanism also. So we know that the stimulants are more effective than the non-stimulants in treating core symptoms of ADHD. Prescription stimulants do not pose significant health risk to individuals when used as prescribed. That's key. That's important. We'll come back to that when we talk about the stigma and the bullshit people talk about. Side effects of prescription stimulants are dose dependent. The higher the dose you go, the more likely you're going to get side effects. Psychosis, seizures, and cardiac events such as tachycardia, which is fast heartbeat, hypertension or high blood pressure, myocardial infarction, or heart attack, and then sudden death are rarely reported in individuals taking therapeutic doses of prescription stimulants. This is very important. Why? Well, I heard that methamphetamines cause psychosis. Okay, so that's okay. I'm going to talk about this in the future, but no. All right, we have to be very careful by what we're talking about. We're talking about the judicious use of prescription stimulants at therapeutic oral doses. We're not talking about smacking the shit. We're not talking about street methamphetamine that has 10,000 other adulterants in it. We're not talking about smoking crystal meth. We're not talking about injecting it into a vein. We're talking about taking a therapeutic oral dose of prescription stimulant. It rarely causes any of those things. Rarely. Okay? That's important. All right? Well, wait a minute. But I heard that methamphetamine was amphetamine. Okay. That's true. But does the pharmacokinetics, the pharmacodynamics matter to you at all? I mean, the route of administration is important here, okay? The amount that you're getting at the rate that you're getting it is important. It's very important, okay? So if you were to take a prescription stimulant, crush it up, and snort high doses, you might get psychotic, yes, okay? Why is that? Because you're increasing the concentration so quickly, all right? So yes. In fact, methamphetamine is toxic to dopamine neurons, right? And that's where that stupid hypothesis or concern that stimulants lead to Parkinson's disease came from. I mean, that's true in illicit use of illicit stimulants, street stimulants. Yes, if you abuse them, you may get yes, you're going to get some problem. You're going to burn your brain, okay? But not if you take controlled therapeutic oral doses of prescription stimulants. Okay, there's a difference. But they're amphetamines. Okay, next time you go to a holiday party, why don't you bring methanol? Why don't you bring rubbing alcohol next time you go to a cocktail party? Pour it in everybody's glass and say, hey, drink up. It's alcohol. Right? No, it's different. All right. Yes, they're amphetamines, but the way you use the medicine or the way that you use a drug matters. All right. We can't forget about that because medical legal bullshit gets in the way, and people now are making up stuff that just isn't true. All right, for some theoretical concern. Meanwhile, we got an opioid epidemic. We got people, dying left and right. It's like, oh man. We have to be very careful about how we talk about these things. Okay, so the stimulants here, there's a list of them with their doses. Sometimes you really need a high dose, but we always start low, go slow, because people respond differently. Some people require lower doses, some people require higher doses, and everybody can have, people can have just different responses to these medicines. Non-stimulants, Strattera, it's a potent norepinephrine reuptake inhibitor. It's effective in adults and for long-term use. Sometimes we use it in patients who have comorbid substance use disorders. For example, if you're abusing methamphetamine right now, probably not going to give you a stimulant, although some people do, because there's some data that shows that it does help. But it doesn't help. It helps get people off methamphetamine. But it is, Strattera can be very useful in patients who have comorbid use of substance disorders or comorbid use of substances. But the problem with the atomoxetine or Strattera, there's a high discontinuation rate due to side effects. Nausea is a huge one. Anxiety, another huge one. Sweating, sexual side effects, stuff like that. Modafinil and armodafinil, they're weak dopamine reuptake inhibitors, but primarily they potentiate histamine and orexin. Histamine is a awakening neurotransmitter, right? So when you take Benadryl or an antihistamine, it's going to make you tired. So histamine, anything with histamine or promoting histamine in the brain is going to be activating. So very few studies supporting its use in adult ADHD. Doesn't mean it doesn't work. We use it all the time. It does work, but modafinil and armodafinil are primarily used for narcolepsy. Clonidine, guanfacine, alpha-2 agonists. Again, very few studies supporting the use in adult ADHD. There's many more in kids, but it has been used in adults, and it has been used effectively in adults. Again, this is a table. This is just another table with the non-stimulants. So many antidepressants, including SSRIs, SNRIs, TCAs, and mirtazapine, have been used in ADHD treatment with varying efficacies. To minimize abuse potential, if you're worried about it, you can use non-stimulants. You can use extended release formulations. For example, Vyvanse is lisdexamfetamine. Lisdexamfetamine is a lysine amino acid attached to dextroamphetamine molecule. The actual lisdexamfetamine molecule itself isn't bioactive at all. If you inject it or snort it, nothing's going to happen. It has to go through the gut where it's cleaved by gut enzymes, so that way the lysine gets cut off. When the lysine gets cut off, it becomes dextroamphetamine, becomes absorbed into the gut wall and then into the bloodstream, and now you have dextroamphetamine. So this is good because it's extended release. There's minimal chance of abusing the drug, and if you try to abuse it, nothing's going to happen. And so it's often used for that reason. You can do contracts. I don't really believe in them. I think it's stupid to have somebody sign a contract saying, you have to do these things in order to get into stimulant. I mean, that's just like, I'd hope that you'd have a therapeutic alliance enough, and you'd have respect enough between each other to be able to say when things are going wrong. And certainly that comes with having no judgment. And I don't hold judgment at all, right? So if you're abusing the drug, or let's talk about it. Let's figure out what's going on. What's going on with that? How can we help? This is something that I think everybody should be doing. It shouldn't be, well, you're bad for abusing this drug. It's like, well, let's sit and have a conversation about it. There's a reason why you're doing it. What are those reasons, and how can we sort of target whatever it is that you're using the drug to help? that just makes more sense to me rather than just being like, no, no more for you, right? No, you're done. It's like, that's not very therapeutic. It's pretty, I don't know. Anyway, so you can do random urine drug screening, you can do pill counting, and of course the Cures database in California is very helpful to prevent doctor shopping. So that's the end of part 4. That was quick. We're going to do part 5 next time, probably after the holidays. We're going to talk about killing the stigma, and this is a good segue because I'm doing a podcast, or I'm starting a podcast, and we're going to be talking a lot about different stigma and ADHD, OCD, their relationship. We're going to talk about depression. We'll talk about all kinds of stuff. Hopefully, have some people come on the podcast and as guests. So we're going to see how this goes. I don't know how this is going to go, but we'll find out. And then this is just the plug-in. Part 2 will probably come up after the break. There's a bunch of questions people are asking about ADHD and OCD. I'm happy to go through and answer some of those. I did a part 1. I'll only answer like 4 questions, but I plan to answer many more in part 2, and we'll kind of go from there. All right, well, thank you for listening, and have a happy holidays.